Okay, Dr Allcroft, thank you for your time this morning and for helping us explain the role of palliative care,
My pleasure.
particularly in motor neurone disease. So, Dr Allcroft, can you tell us about the role of palliative care and perhaps what your team members might do?
So, palliative care as a philosophy really wants to look after family and patient and try to cover all aspects of care, be that someone's physical needs and their mental and social and emotional needs, and for some their spiritual and religious needs. I guess palliative care increasingly is being involved and asked to see patients earlier. Initially, palliative care was involved with mainly patients who had a malignancy, a cancer diagnosis, but increasingly non-cancer patients are being seen by palliative care teams and at an earliest point in their care. Particularly with motor neurone disease, I think if someone is diagnosed with motor neurone disease, they should have the opportunity to see a palliative care clinician, at least a senior nurse, social worker or a palliative care physician, to have the opportunity to explore a number of issues that they may be troubled by, because sometimes there's a concentration on just the physical aspects, not the emotional aspects of what's important, who's important. So I think an early referral is important.
And an early referral to palliative care, is that something that's simple to do? Is it a matter of simply picking up the phone or sending a referral form?
So obviously it depends on what area you live in. In metropolitan regions, then there are specialist palliative care services. In the rural regions, many of the rural regions have senior nurses as part of their palliative care team, and all of those rural regions have links back into metropolitan teams. So I'm based at Southern Adelaide Palliative Services, and we look after aspects of the Barossa Hills, Fleurieu Peninsula, the Limestone Coast down towards Mount Gambier, and also up into the Riverland. So we actually help to manage patients in those areas, and all of the other services in Adelaide look after rural locations. So it can be as simple as a phone call initially, but then either a formal referral via the statewide referral network process.
That's good, and I think on this online tool that you will be using, there will be click-through links directly to those contacts. Dr Allcroft, can you tell us a little bit about perhaps what palliative care isn't? I'm aware that there are a lot of myths and people are reticent to refer to palliative care early, but maybe you could explain why that's really important.
I guess palliative care is not seen as a sexy title, and I don't want to go there because that's just the last days of my life. And I understand those fears. But it's certainly not something where is just the last days of life, because we may be involved with patients very early on, sort out some symptoms, be they physical or psychological. Everything settles down, and then we fade back into the background a little bit, having a presence but not being the primary drivers of care.
So that would mean that the primary care team can reach out to the specialists involved in palliative care and be supported to continue to help, particularly in rural regions, continue to help manage symptoms at home.
I would always try to make sure that particularly our general practitioners are the conductor of someone's care, the conductor of the orchestra, and as a specialist palliative care service I provide specialist support. I do the solo bits that I may be required, but then step back and form part of the orchestra. And I guess I say to many patients that from my perspective, if everything's reasonably stable and I don't need to do much, I'll stay in the background, but if things are going pear-shaped, I'll step up and I'll do more up front.
That's wonderful.
And I'll become the primary driver of care. So it pleases me if I'm in the background, that when the time comes, and it will come with motor neurone disease because it is a progressive illness, then patients know that it is a progressive illness. Having seen and known me across, be it 3 months or 3 years, they feel confident to be able to reach out when that time comes again.
Excellent. So I would say then, or ask the question, so being able to respect or know patients' wishes about their future care would be an important part of the work that you do?
It really is almost a critical part, and having those conversations, and it's a series of conversations and discussions early at an appropriate time, not forcing the issue, because not everyone is an information seeker, but giving the opportunity to allow me to understand and to document, either in my notes or formally in an advanced care plan, what an individual might want and what they would not want.
Very
and
helpful.
What quality of life would they envisage that they would decide, I would not want to be kept alive artificially in these circumstances. And also to nominate a power of attorney or a substitute decision maker in the advanced care directive language, someone that could make decisions and stand in their shoes should they be unable to. And particularly with motor neurone disease, we'll go to great lengths to communicate with patients, be that with handwriting or typing, be that with eye gaze technology, be that with a yes-no answers and eye blink, to ensure that I can communicate with patients. But an end-of-life conversation with someone who is anarthric, when you have to ask yes or no questions, is a very blunt, direct way of communication. But having had series of conversations early across time allows that confidence to be built up, that rapport to be there, and it to be documented ahead of time. I will always say, if you get a bladder infection, we would treat that. If you had a simple chest infection, that might be something that you would treat. But if it became to the point that you needed intubation and ventilation, is that a step too far? Is that crossing the line? And it's not something that you would like. So early conversations is important. The other reason, particularly for motor neurone disease, is that as the disease progresses, we see an increasing appearance of frontotemporal dementia, which again I take great lengths to explain to patients and families. It's not dementia as in what the general public appreciates with Alzheimer's, but it's subtle, it's behavioural, it's a rigidity in thought, there can be profound apathy, there can be an obsessionality. So it's very important to have discussions early on, because we know by the time someone gets to advanced motor neurone disease with what we would call King stage 4, with arms, legs, swallowing and speech involvement, probably 80% or more of those patients will have a degree of frontotemporal dementia, and that impacts on decision-making ability.
Right. So what I'm hearing is that it's particularly about quality of life and keeping a lid on symptoms. Equally, can I ask the question of where palliative care might be delivered? I think there are some myths around it being about death and hospices, but that's very different here in South Australia.
So yes, increasingly we try to look at the metric of preferred place of death.
Yes.
And home death for some is what they would like, but the preferred place of death, because some people may feel that the hospice is the safest spot for them, Others may be in a residential aged care facility, and that's their home, and that's where their carers are, and they feel safe and secure. So palliative care can take place anywhere from an acute care hospital, and that's site of death to place of death, to an acute care hospital, to a hospice, or increasingly to a home environment. We will go to great lengths to try to achieve that, but it does require more than just a single carer. Unfortunately, we can't provide a 24-hour nursing support service nor 24-hour medical support services face-to-face, but certainly there is telephone consultation. Telemedicine helps with that visualisation. The paramedics provide after-hours cover and care as well. So home death is certainly what a lot of people would aspire to, but it does require a team effort to ensure that happens.
Caring for a person at home in palliative care stages of life can be very difficult and quite onerous on carers, family and other members of the care team. Can you tell us a little bit about how they might be supported or what they might go through?
Caring is a relentless task. They are tired, they're exhausted, they're sleeping with one eye open. I don't think we get to provide as much support to carers as we would like to. There is emotional support, but it's providing information, providing tools that might help make things a bit easier, providing professional resources that might come in for some of the heavy lifting, washing, repositioning, having a carer there for a number of hours a day, paid carer is helpful. Although we have some disparities in the Australian system, and if you're under 65 you can gain access to the NDIS, and once that is in place we can get carers for many hours. But for our elderly above 65 who are reliant on my aged care, they may get very little support, and I think we really need to be able to provide the support for our elderly who have no easy access to many hours of care. I think we try to put in physical supports, time-outs, some volunteers. We need the community become more involved, really, to support their own community members in caring. But it is relentless, and there's actually not enough for carers and supports in time out.
Maybe that's an advocacy campaign for the future.
Yes.
So talking about supporting family and carers, but once a person with MND has died and the family are looking to heal from that, what type of support or bereavement support might be available to people through the palliative care team?
So through the palliative care teams we have a bereavement service which we will try to touch base with many of the patients that we've been involved with and their relatives. I think it's critical for the bereaved relatives to link in with their GP as well. I certainly, in the early stages when I'm catching up with a family member, ask how they're getting on, how did they cope, what are their plans for the future, but to acknowledge that the next 12 months will be a rough period, will be up and down, there will be days that are better than others, and then for most at some point it'll all settle. For those that have complicated bereavement, which is prolonged, distressing, there may be a formal referral from the bereavement coordinator to mental health services and to their GP, who I think is a critical element.
Thank you. I'm not sure if there's any other direct questions that I can ask, but is there anything else that you would like to add about the importance of palliative care for people with motor neurone disease?
This disease, unfortunately, does not have a cure at this point, and the medications to date slow the progression of it down. So therefore, for most people with motor neurone disease, they are going to die much earlier than they had anticipated. And it's a group of patients who are previously usually quite a fit, healthy group by and large. When someone's diagnosed with motor neurone disease, I think it's important that gently it's introduced, but palliative care is front and centre from very early to be able to share that journey or answer those questions, to be the support person early on, to be an advocate for those patients, because there is complex decision making. Do I have artificial feeding or not? What are the benefits of that? What are the drawbacks? Will non-invasive ventilation be of value to me or not? I'm a believer in, I'll rephrase that. As the patient might say, I'm a believer in euthanasia. That behoves the palliative care doctor to explore that, discover it, ask questions, because we know, again, as a group of patients, those with motor neurone disease do seek out voluntary assisted dying processes more than the average compared to someone with heart failure or a cancer. Okay. So it is important that we are seeing people early on and supporting them, their physical needs, their mental health needs, their spiritual needs, what makes them tick as a person. And they're not just someone with motor neurone disease, they were the person who, before they got motor neurone disease, and what makes them tick and what's important to them.
Well, thank you very much for your time today, Dr. Allcroft.
My pleasure.